Welcome to the CINP Leader Panel. And my name is Siegfried Kasper. I'm the president of CINP, and together with my dear colleagues, we have today a very important topic, is new treatment for treatment-resistant depression. There is Professor John Krystal, Professor Tamminga, and Professor Gobbi with me. Professor Krystal, may I ask you to start with new treatment for treatment-resistant depression?
Thank you, Professor Kasper. I think this is really one of the most exciting moments in a long time in terms of new medication treatments for treatment-resistant symptoms of depression. In the past year, after a very long time, decades, we have two new antidepressant medications approved by the United States FDA for the treatment of depression. One of these medications is S-ketamine or Spravato, which was developed by Janssen Pharmaceuticals, and the other one is Larissa, which is brexanolone, which is developed by Sage Pharmaceuticals for the treatment of postpartum depression. What these two medications have in common is that they aren't directly targeting the signaling of the serotonin system or the norepinephrine system, which are, of course, the systems in the brain that have been targeted by all prior treatments for depression. And so that suggests that we are shifting and broadening the focus of the biology that we're studying in trying to get a deeper understanding of the biology of depression. And it also seems that this might be a time when the effectiveness of drugs acting on both glutamate and GABA systems are the tip of the iceberg for these medications, with a variety of other medications pursuing related mechanisms being studied by several different pharmaceutical companies.
So it's a new, exciting mechanism of action, which seems to be very different to the monoamine mechanism of action, which we studied over the years over and over again. That doesn't mean that this story is dead, but it expands the field. Is this the understanding of the situation?
I would assume so, that these medications are shining light on areas of the biology of depression that previously hadn't been studied and which complement what we understand about the biology of how antidepressants work in the brain. I think one of the exciting things about the new medications is how rapidly they work. Within days or weeks of starting treatment, people can expect that a reasonable likelihood that they will benefit from these new medications.
Professor Tamminga, these compounds have been studied also in schizophrenia. So could you give us some information how these glutamatergic compounds worked in schizophrenia?
Well, they've been studied in schizophrenia mostly because, by accident, mostly because we used GABAergic compounds for tardive dyskinesia. And GABAergic compounds are very potent at modulating the motor system. They have lots and lots of side effects. But I was just about ready to ask Dr. Krystal why in depression you don't try a GABA antagonist, which would be consistent with the argument that you were laying out. There are GABA agonists and antagonists that people have used in motor disorders.
Yes, I think GABA antagonists actually are an area of active study in terms of novel antidepressant treatment development. It's an interesting challenge because we want to have drugs that have the possibility of increasing transiently cortical excitability and glutamate release, but we don't want to make people anxious and have panic attacks.
So it may be that the combination of actions that ketamine has, some glutamatergic actions and other yet GABAergic actions and other perhaps glutamatergic or undiscovered actions might be the key. Perhaps like clozapine has a variety of actions that are all exerted at the same time.
Well, I think this is one of the controversies in the field right now, which is ketamine only acting as an NMDA glutamate receptor antagonist? And even so, even if that were true, is it really the network effect, the broader effect of multiple effects on multiple signaling mechanisms that are affecting the antidepressant effects of ketamine.
Dr. Gobbi, what is the situation in Canada? Are the patients looking forward to this ketamine approach? Do they approach you, doctor, I want to have this medication, or how is it viewed?
Yes, now there are some clinics in Canada that use endovenous administration of ketamine, and now esketamine is under study by Health Canada. So a lot of people, especially people with treatment-resistant depression, is looking for having the esketamine in the market.
The reason I'm asking is because in Europe, unfortunately, it's not as yet approved. But a lot of patients ask me, doctor, can't I have this treatment? Why can't I have this treatment? And it's always very difficult to explain them. It's not as yet approved. But I would like to ask Dr. Krystal also from a very clinical point of view. So like when patients talk to you, what kind of experience do they tell you? What happened in them?
Well, I think predominantly people report beneficial clinical effects of ketamine. In the United States, ketamine is used for patients with treatment-resistant depression, and Spravato, the FDA-approved esketamine, is particularly limited to patients who've had failed treatment and have other signs of treatment-resistant depression. And what's been striking is the very high rate of clinical response in clinical trials so far. So generally, in the clinical studies, the rates of clinical response in treatment-resistant depression have varied between about 50 and 75%. And in clinical practice, you sometimes see even higher rates of response, partly because the placebo effects work with you in clinical practice, whereas in the clinical trial, you're thinking of the differential efficacy versus placebo, so the placebo effect is in a way subtracted out from the efficacy of the drug. So I would say that overall the experience has been pretty favorable in terms of both the tolerability and safety of and efficacy of ketamine and esketamine.
Sometimes the patient, since we also use it in our university hospital, they tell me, well, doctor, is it necessary to have the derealization in order to get the antidepressant response? Or sometimes they say, well, the derealization, couldn't we work on this because I had this and this imagination during this time? So could you address also this topic? Is it necessary?
So actually, you almost, Dr. Krystal almost got around to talking about that this morning, but you didn't show the correlation. And my question was, is there a correlation between the derealization and the antidepressant effect?
Yeah. So generally speaking, derealization as a symptom has been a sign of adequate target engagement, so that there are high rates of the presence of derealization in people during the brief period of time where ketamine is in the body. But one of the, as I said this morning, one of the pieces of evidence that the derealization may be a sign of target engagement as opposed to a means through which the drug works is that you increase the intensity and prevalence of derealization by increasing the dose from 0.51 milligrams per kilogram to 1.0 milligrams per kilogram. However, in that transition, you tend to reduce the effectiveness of ketamine so that the response rate didn't seem to be as high, or at least not as statistically robust at 1.0 milligrams per kilogram as it was in the lower dose of 0.5 milligrams per kilogram, where the derealization was less severe and less common.
Although the studies have been done predominantly in treatment-resistant depression,
Yes.
what happens in regular depression? Has anybody even tested that?
I'm not aware of any well-powered study in non-treatment resistant depression. what we have
Is
seen...
that just waiting to be done?
It probably is. It is something that I think people will do. What little insight that we have is that we used a statistical approach to look at, in a study conducted in Taiwan by Dr. Tom Su and his colleagues, we looked at a statistical approach that enabled us to look at people who had treatment-resistant depression but mild symptoms, treatment-resistant depression but moderate symptoms, and treatment-resistant depression but severe symptoms. And ketamine produced statistically robust clinical benefit in the patients with moderate and severe depression, but not in the patients with mild treatment-resistant symptoms.
That would be kind of even a biological marker, right? So from a clinical point of view, because very likely they have a different biology, first episode and then second, third, fourth episode. But may I ask you once more, so because there are also papers about this, you know, that you could use this deodorization then for better work in psychotherapy.
Yes. So
I always say, no, this is a side effect. Don't cover this side effect with future talks.
You know, this is really an interesting question, and it's a question that has become particularly raised by groups of people who are also studying the serotonin hallucinogens like psilocybin. That group only administers psilocybin as a treatment in combination with two therapists present in the session to talk them through some experiment. One of the paradoxes about ketamine is that it is a powerful amnestic drug. It significantly impairs memory encoding. And so I have heard from patients that they had a meaningful experience during the ketamine infusion, but they can't remember what it was. And so that tends to make me think that maybe the insights that the ketamine effects on the cortex, it interferes with associative reasoning and neuroplasticity and other properties of the tuning of the cortical activity. It's possible, I wouldn't rule out the possibility that people could use that productively, but we have thought that that probably is not a very productive time.
No, thank you very much for this important topic. Carol, you have something to add?
Well, I was just going to say that now in schizophrenia, where we have a dearth of new treatments, much like John described in depression several years ago. But now people are returning to using psychotherapy and psychotherapy-oriented techniques in early schizophrenia, early psychosis, in order to maximize the effect of antipsychotic drugs and to target treatments to psychosocial aspects. So I think that there's an interesting return to psychosocially oriented treatments in addition to medications.
No, very important, right? Dr. Gobbi, you?
Yeah, I would like to add that we didn't mention so much the allopregnanolone for the treatment of postpartum depression. In terms of translational psychiatry, this is a very good news because for more than 50 years, basic researchers studied the effect of neurosteroid on mood, on cognition. So finally, we have really a drug approved by FDA can help women with postpartum depression. This, I think, is very important. And don't forget, in 50s or before, women with postpartum depression were placed in asylum for the rest of their life. Now with these new drugs, we can treat women with postpartum depression in less than 1 week. This, I think, is a big advancement of psychopharmacology and translational psychiatry.
You know, and one of the other exciting parts about the brexanolone study is that this company that developed it has developed another version of a neurosteroid drug, Sage 217, which they just published the results in the New England Journal of Medicine as a treatment for depression, not treatment-resistant depression, but sort of first-line depression, and had very encouraging results. So I think we're seeing bridges and connections made, new treatments emerging in a variety of different areas that I think is really very
exciting moment.
Yeah.
Yes, thank you very much for participating. I think the news are exciting. This year is exciting. We have 2 new compounds which are for our patients, and we have to remember those are compounds which have been studied very thoroughly before already, but now by the help of the pharmaceutical industry, Janssen on the one hand side, Sage on the other hand one side, brought it then in a very rigorous development manner also to the market. So we should be thankful also for these companies for doing these studies, and I was also part of these studies. And so there will be a bright future for psychopharmacology when we look at all the different other compounds which will come for this so-called group, treatment-resistant depression. I'm quite sure we'll leave this term soon when we realize there's another biology behind it. Thank you very much.